And there we are. So we want to just be aware to not include any confidential patient health information during the session. And all audio is being broadcast, so if you need to mute, there is a mute button right there, or you can use your own hardware as well, of course. Video is on. I'm not seeing anybody on video, so something must be a bit awry. But if you do see it and you have a camera, you can stop or start your video using this icon at the bottom of your screen. And we also have our chat box that you can use, and I'll chat a quick one out there just to let you know where that is. It'll pop up. If you do wish to receive a CME, CEU, or attendance certificate, you need to announce your name, and we'll do that in just a moment during roll call. If you are called on for some reason for a question, then you can feel free to say pass. And again, those icons for audio and video in our new template, I've gotten rid of this slide. Our disclosure and accreditation statements are on screen now. We're required to post those on our live session in order to offer the CMEs to you. And at this point, if you are on audio, either through the phone or through your computer, go ahead and unmute. Let us know you're out there, and we'll get started. And one moment, I'll go ahead and pop up the chat box for everybody. Oh, there we go, Jillian Mayer. And John Helm. Welcome back, John. Looks like everyone's going to be chatting in at this point, and I also have a list of participants, so we'll go on that as well. And at this point, I think we should go ahead and hand it over to Dr. Mason.
Thank you. I have a quick announcement. One is, as always, thank you so much to Kevin and Michelle and everybody at Envision who makes this possible. We really appreciate it. The second is, if you have any ideas for any topics that you would like to hear about or specific speakers, please email me. It's Melissa E. Mason, MELISSAE@gmail.com. I would love any suggestions and any ideas for topics. So without further ado, we'd like to thank Dr. Anjali Subaswamy, who is a pediatric intensivist at the University of New Mexico Hospital. She is the Quality and Safety Officer for the Department of Pediatrics and has created a pediatric stroke process for UNMH. So without further ado, Dr. Subaswamy.
Thanks, Melissa. Thank you for this opportunity to speak to this audience. I really appreciate it. So our goal today is to discuss pediatric acute ischemic stroke a little bit. It's sort of a broad overview, and then I want to talk with you all about some of the clinical programs that we're trying to put in place at UNM to serve this population a little bit better. So let's see, forward. Okay, so objectives are to raise awareness about pediatric stroke, and then we'll have a little bit of a discussion about the use of TPA in pediatric stroke, and then I'll do an overview of the current state of the UNMH pediatric stroke protocol. So the epidemiology of acute ischemic stroke in pediatrics is on this slide there. It's not that common. The published incidence is 2.3 to 13 per 100,000 children. Of that range, about 8 of that 100,000 are neonatal strokes, which are classified into a separate subcategory. The etiologies are different, the manifestations and the treatment and the impact are different. So we're not really addressing that today. In total, including all comers, we have about 3,000 acute ischemic strokes per year in the children of the United States. So if you look at all that and you think about the population of New Mexico and the pediatric patients we see both in the outpatient and inpatient setting, you would expect that we would hardly ever see that. Nonetheless, in that 2-year span there, 2014 to 2016, which was the first 2 years that I was here, we had 8 pediatric acute ischemic strokes come to UNM, and that was much, much higher than I think anyone had anticipated. There are certain subpopulations that are more predisposed, which I'll talk about in a minute, and we don't really have a lot of those subpopulations in our state, which is another reason that it was surprising that we would see, even if it's 4 a year, that's 1 a quarter. That's still way more than you would expect given the published incidence. So they say across these 3,000 kids that have strokes every year, there's up to a 10% mortality, and up to 20% can have a repeat stroke, usually those with predisposing conditions. However, the really impressive statistic to me is that up to 75% of kids will have long-term deficits, and those can be something as simple as attention problems, or it can be chronic headaches, it can be seizure, it can be learning disability, motor disability, and obviously these deficits are occurring in a really crucial phase of development and will determine the quality of their lives for years to come, and by extension, impact their families' lives for years to come. So even though the numbers are small, I think the impact of these morbidities is pretty huge. What I was talking about. So this is sort of to put it in some perspective. Globally, the kinds of kids that have strokes, the most common are kids with sickle cell disease. And this is a slide from one of the national stroke experts at Vanderbilt. Her name is Lori Jordan. And she just is sort of looking at the country of Nigeria, which has about 100 to 150,000 children born every year with sickle cell disease. It has the largest burden of sickle cell disease in the world, and by extension, the largest burden of acute ischemic stroke in children in the world. They say for every birth cohort in Nigeria, because of this background situation, about 15,000 children will have a stroke by the time they're 15. So that's pretty impressive, right? That's sickle cell disease. Now, I talked to our pediatric hematologist at UNM, who I think has eyes on all the kids in the state that are known to have sickle cell disease, and she said that we only have about 10 total patients. So this particular subpopulation is not common here. This is not a common cause of stroke here. But if you have kids that move in from other parts of the country, this is definitely something to keep in mind. If you look at this slide, it's a little bit wordy, but it's a nice summary of the various causes and risk factors for childhood acute ischemic stroke, and this is from 2017. So the broad categories are arteriopathies, and there's a few examples there: moyamoya disease, primary CNS angiitis, cerebral arteriopathy. Second category would be cardiac disease, so congenital heart disease, cardiomyopathies, arrhythmias, having procedures like heart surgery or caths, and being on ECMO, which they put under cardiac disease. Inherited thrombophilia, obviously, is kind of self-explanatory. Acquired thrombophilia. Some of these can be drug-induced, like chemotherapeutic agents such as asparaginase. That is something that we do use in our populations here. Sickle cell disease, malignancy of any kind, congenital vascular syndromes, inborn errors of metabolism, particularly mitochondrial disease, and rheumatologic diseases, which we do see a fair amount in our practices. So just sort of going back to the basics, why does this happen? It's because you have a confluence of endothelial wall injury plus stasis of blood plus hypercoagulability. And I thought this was kind of a nice way to look at the different risk factors as well. So if you have cardiac disease or arteriopathies, which may or may not be associated with inflammation, this will sort of provide the predisposing condition of stasis of blood. And then going clockwise, if you have cancers, or if you're on chemotherapy, if you have congenital hypercoagulable states, or in certain situations if you're really dehydrated, especially if that's an additional risk factor on top of a primary risk factor, this all gives you that predisposing condition of hypercoagulability. And then continuing clockwise around that diagram, If you have arteriopathies or trauma, you certainly could sustain vessel wall injury, which is the third leg of that Burkhouse triad. This is an abstract from Pediatric Neurology from a couple of years ago, and it's looking at a case series from Johns Hopkins that was collected between 2000 and 2009. And they looked at, in a single institution study, for children with cancer and their incidence of stroke. So in 9 years, they looked at about 1,400 children with cancer, and they found that 15 of those kids had a stroke, which is only about 1.1%. But still, important to be aware and important to act quickly if you do think that one of your kids with cancer that you're treating is presenting with focal neurologic signs or a new neurologic finding that may indeed be the presentation of a stroke. Of these 15 kids, 7 had intracerebral hemorrhage and 5 had acute ischemic strokes. One of those ischemic strokes was then followed by intracerebral hemorrhage or hemorrhagic conversion. 3 of them had a cerebral venous sinus thrombosis, which again is sort of a different subcategory of stroke, but in the end it all injures brain cells, so it all has the same impact, I think, down the road. When did these strokes occur in these kids that had cancer? The median time was about 5 months after their diagnosis, and then of those kids that had the strokes, the 15 kids, 10 of them had hematologic malignancies, most commonly leukemias, and 5 of them had brain tumors. The other interesting thing was, and not sort of surprising, I suppose, but 5 of the 7 kids that had the hemorrhagic strokes did have thrombocytopenia at the time with platelets less than 50,000. So the conclusion of this pretty nice review was that stroke has a prevalence of about 1% in children with cancer. The most common types are equally distributed between hemorrhagic and ischemic, and children with leukemias and brain tumors are at the greatest risk. This is one looking at the incidence of arterial ischemic stroke in children with cardiac disease, and this is a case series in the same time epoch from the University of Melbourne in Australia. So they looked at a total of 76 kids that had cardiac disease and acute ischemic stroke. Again, the mean age of diagnosis was about 5 months. Previously, it was 5 months after diagnosis of cancer. This is like an actual chronologic age of 5 months, with an interquartile range of 0, which is birth, and 58 months. So the different types of cardiac lesions included 55% of kids had cyanotic congenital heart disease, 29% had acyanotic congenital heart disease, 8% had just cardiomyopathies, no anatomical problem, but a cardiomyopathy or a myocarditis. 4% had acute infective endocarditis, and 4% had primary arrhythmias. Again, we do see all of these patient populations here in New Mexico, and the numbers are small, which I think makes it a little bit more difficult for us to be tuned into some of these less common but potentially very significant complications. It's also important to note that in 52 patients, which was 68% of their cohort, the stroke did occur after a procedure. So 41 of them happened after surgery. The incidence of that was 4.6 strokes per 1,000 surgical procedures. And 11 of them happened after cardiac catheterization, with a pretty low incidence of 1.7 strokes per 1,000 catheterizations. Just to put that in perspective for us, we probably do, so we've had a active cardiac surgery program at UNM for the past 6 years. It's currently on hold because our surgeon is moving on to other projects. But in that 6-year period, we had a relatively low volume of about 50 cases per year. So if you say in about 6 years, we did 300 surgeries, we didn't have any strokes as complications of those. While that's great performance and we're happy about that, it does fall within sort of the published incidence. So it's a, again, uncommon complication, but significant when it does happen. We do cardiac caths at our center as well, and I'm estimating we probably do about 30 per year, give or take, 10 to 15 on either side. So say in a 6-year period, we did, say, 200 caths, and again, no strokes from that, which again is well within the published incidence. So when do these usually happen? The median time from procedure to diagnosis was about 3 days, with an interquartile range of 2 to 7. Oops. Sorry about that. Okay. So how would these kids present? You know, when you get down to it, it's pretty similar to how adults present with stroke. Really, it's just a matter of having it within your framework as a possibility. Because a lot of providers in all settings, you know, you just don't see kids presenting with stroke. It's not the main thing that happens. So it's certainly not in our first or second or third line differential. So just to put it there, I wanted to show you that 94% of kids in this review who had ischemic stroke presented with hemiparesis or a new focal neurologic deficit. And you can elicit these things from history. You just have to sort of put it into your framework that, oh, it could actually be a stroke. 28% had a change in mental status, 22% were headaches, 16% were seizure. I think this is interesting because pretty much any time a kid that was mostly well has an acute neurologic change, we'll find a way to say that it could be a seizure. And that's legitimate because lots of kids have lots of seizures. They present in lots of ways, so it is a very common thing, whereas stroke is very uncommon. But it's just a little bit of a tricky issue because sure, you'll have a lot of false positives, you know, like if you have a kid with a focal neurologic deficit and you're like, oh, maybe it's a stroke, maybe we should image them. A lot of them will be stroke mimics, and we'll go into that in a couple of slides. It's true, they will. But a couple of them will actually be strokes. And if you catch them early and you intervene early and you treat them early, all that time that you're saving is actually brain that you're saving. And I think it's an ongoing discussion, both in terms of how aggressive of an intervention it is to go down that pathway, how scary it is for the family, the cost of the extra imaging, the time, versus how many you're actually going to catch and treat. So you do need to have clinical equipoise about it, but my purpose here today is to encourage you to act and be wrong and be able to tell that parent that it's definitely not a stroke, especially if the kid has any risk factor, or if they present with a very clear new onset focal neurologic finding. It does behoove us to rule it out, I think. Oops. So the cases that we saw in my time here, which is about 3.5 years, it was 8 in the first 2 years, and there's been another 4 or 5 in a year and a half since then. These are a couple that really stood out from 2016. So we had a 17-year-old, previously healthy, no risk factors, who had sudden onset of slurred speech followed by unilateral weakness at school. He did collapse in the course of all this, and there was that whole conversation of, oh, he was kind of shaking, we think he might have had a seizure. But he did get rushed to the hospital, they did some scans, and it turned out he had a stroke that was diagnosed and then treated. We had a 7-year-old male who was previously healthy, who in the morning fell down the stairs as he was coming down to breakfast. And everyone acknowledged that that was odd, but he seemed okay after that. So he didn't immediately get taken to the hospital. He was sitting at breakfast. He seemed disoriented. His speech was garbled. He complained of blurred vision. And when he came to the ED hours later, the whole story didn't add up. But still, nobody called a stroke alert, right? They were just like, something's off. Did he have a drug ingestion? Is he having a partial complex seizure? So eventually he got scanned and he had bilateral thalamic strokes, which explained his symptomatology. The third case on there is a 14-month-old male who actually had risk factors. He's a baby with chronic renal failure who also had a known atrial septal defect, and he had a port for central access because of his chronic hospitalizations and blood draws and things like that. So he had an intracardiac communication, and he had a central line sitting at the SVC-RA junction. This kiddo, presented with obvious left-sided weakness, which the parent noted, called in about, and because kids don't have strokes, the nurse helpline advised, to watch, let him rest, and see what happened. So he woke up 12 hours later with profound left-sided hemiparesis, got scanned, and was clearly diagnosed with a stroke. I will say all these kids ended up doing pretty well. So that's the other amazing thing about kids. They seem to recover pretty strongly. I want to sort of compare and contrast two other cases besides the 3 that I just mentioned. of two 14-year-old males that presented similarly and had very different outcomes. One 14-year-old male, again, was previously healthy, was at school. He had acute hemiparesis and slurred speech. He collapsed. They thought it was a seizure. After he came to the ED and got imaged, he was diagnosed with the right middle cerebral artery acute ischemic stroke. This boy was at a center where they had a stroke program. The adult doctor that saw him was comfortable giving TPA intravenously. He got TPA within the 4.5-hour time frame. And then when he got here, we're the referral center, when he got here, he was also eligible for thrombectomy, which is a neuroendovascular procedure where either a neurosurgeon or a neuroradiologist goes intravenously into the cerebral vasculature and mechanically extracts the clot. So it's intravenous or intraarterial or both, depending on where they need to go. So this young man who really had a clot in a major vessel that supplies the most of 1/2 of his brain survived with mild deficits. And I think that's a really eloquent example that sometimes adult therapies can work in kids. Now, this is a 14-year-old, it's not a 1-year-old. So, something to keep in mind. The other case is, again, a 14-year-old male who, again, was previously healthy and collapsed in gym class. This guy seems like he had complete loss of consciousness with really no neuro exam initially that anybody could report. He did awake a few hours later at hospital with obvious hemiparesis. In these 5 to 7 hours that transpired between him collapsing and waking up, he had a normal non-contrast head CT, and no further imaging was done until he woke up with obvious unilateral weakness. Then they did, I think, a CT angiogram and an MRI, and he very obviously had a large left-sided middle cerebral artery clot, a stroke. At this point, even though by age and size he could have been offered TPA, he had missed the window. It has to be given within 4.5 hours of the last known normal neurologic exam. That's the criteria in adults, and they have good evidence in adults. In kids, we unfortunately have no evidence because the incidence is so low, and it's hard to get all the centers to work together to do the same thing, and a lot of kids miss the window because nobody's thinking it could be a stroke. So you really need to be very strictly within the 4.5-hour window at a center that's familiar with giving TPA and can deal with complications such as intracranial bleeding if you're going to consider giving it. So this kid had all those things. He was at such a center where they were comfortable giving TPA. It's just he missed the window. So after he woke up, he got neuroprotective care. He was placed on Lovenox or aspirin or some appropriate anticoagulant. And he seemed to be doing okay, but 2 days later, he had what's called malignant extension of his thrombus and re-infarcted the remainder of that half of his brain, which then swelled, and essentially he died from brain death as a result of extension of his large stroke. So on the one hand, kid got aggressive, timely therapy, survived with mild deficits, and on the other hand, was given appropriate neuroprotective care, which is the standard in pediatrics, but that wasn't enough for the nature of his injury at that time. So if you look at sort of these two images, I just wanted to try to illustrate on the left, as you look at the screen, on the left is the imaging of the kid who survived, and you can see a good chunk of his brain is involved. It's not a small stroke. And then on the right is the imaging of the kid who didn't survive, and it also is a good chunk of his brain. So we're looking at an MRI compared to a CT, which is why they look a little different. But in terms of risk factors for doing poorly, they say the amount of territory involved is important and where in the brain is important. So this is peripheral, which is usually you can have more injury and still do well if it's on the outside versus if it's deep within the brain near some of those eloquent structures where a little bit of swelling causes a lot of damage. So both of these are peripheral. They're both large volume, but as I keep saying, the outcomes were very different. So why were they different? And these are some of the things that we consider. The infarct volume, did they get TPA, did they get thrombectomy, and was there lack of recognition of infarct extension? A lot of times, like in the case of this second child that we're talking about, there are signs. It's just a matter of going that extra step and considering the thing that never happens, considering that it might actually be happening. So this kid had a headache. He had such a bad headache that he had to quit his physical therapy early. He had such a bad headache that Tylenol didn't work. He had such a bad headache that he got morphine. And, you know, in a kid that already had a stroke, in retrospect, you can say, oh, it's not just a headache. It could be something worse. So there are certain pediatric specific issues in stroke diagnosis and management, and they apply to teens as well. Stroke mimics are pretty common. It's about 1 in 3 kids that present with signs that could represent a stroke. One in 3 would be a stroke mimic, so 30%, which is pretty high, I suppose. In adults, it's about 10 to 20%. So it does happen in adults. They also have stroke mimics, but they also have a lot more strokes. So sort of the risk-benefit ratio of intervening is different in them versus kids, and I do recognize that. So if you have a kid that has focal deficits but is still conscious and perhaps agitated, getting an MRI can be difficult. You might need sedation. You may not always have the staffing. But we do prefer MRI to CTs or CT angiograms because of the radiation exposure with the CT and the CT angiogram. It's a lot of radiation. So there are some specific sequences that I've listed up there that have been validated at like Mass General, Seattle Children's, and Vanderbilt as being very helpful in this particular situation where you're trying to rule out acute ischemic stroke. They're helpful because they effectively rule out a large volume intracranial hemorrhage, and they effectively rule in an acute ischemic stroke. And if you do an MR angiogram, it can tell you what vascular distribution that clot is actually in. The sequences are axial DWI, GRE, ADC, all those other things. I don't really know what they all stand for, but you can complete them in 10 to 15 minutes. And most kids can either be given a little bit of anxiolysis or be held down or bundled or swaddled, or usually you can do some situational management to do a 10 to 15 minute scan. A lot of kids end up getting benzos anyway because the question of seizure. So if you can time your empiric benzo with your scan, then that's another way to work through that. The issue with treatments, like I was saying before, is that there is not evidence either about safety or efficacy. Off-label use that has been ongoing at large centers around the country does suggest that TPA is safe to be given intravenously in kids, but you know, even anecdotally, we had one patient that I took care of who got TPA for an appropriate indication, and then a day and a half later had an intracranial hemorrhage. And at that point, you're trying to parse, is it a complication of TPA or is it just a hemorrhagic conversion of his ischemic stroke? And without a large, well-powered study, it's really difficult to make conclusions. Because of this lack of data, there is something of a lack of consistency amongst some of the referral centers around the country. So if you look at places like Johns Hopkins or Seattle Children's, Northwestern, and then I put UNM in there, we all have sort of the expertise and the systems in place that we feel comfortable giving TPA to kids who meet the criteria. And I'll go into what expertise that is in a little bit. But Pittsburgh, the Children's Hospital of Pittsburgh, which is one of the leaders in the country, especially for neurocritical care, they don't give TPA, even though they have all the infrastructure in place. They feel like the lack of evidence prohibits that. A big issue with pediatric stroke is the delay in diagnosis. And mainly we think this is because of the low threshold of suspicion. Also, the higher incidence of stroke mimics, and a really sort of common one that you hear talked about a lot is Todd's paresis or Todd's paralysis after a seizure. And we did actually have a case of that just last week. She did get scanned, an MRI. We did call a stroke alert, and everybody came, and it wasn't a stroke. Great. So I thought that went perfectly, but I turned around and looked at the mom, and I'm giving her this great news, and she's still totally traumatized. They had gone from one hospital to another hospital in an ambulance, and 15 doctors converged on them in the ED, and then she got scanned for 20, 30 minutes, and then the mom was completely shell-shocked. And I realized that even though the intra-hospital system might be adequate or even good, there's still a lot of education and sort of situational development that we could be better about. There's also lack of education about risk factors, which we're trying to address through lecture series like this. And then it can be difficult to assess focal neurological deficits in the smaller kids, especially the ones that are nonverbal. Having said that, there was that 14-month-old that was fairly obvious in retrospect. This is just a slide about stroke mimics. It's a series from Children's Hospital of Philadelphia from 2008. They looked at 143 kids, and 30 of them had stroke mimics, which was an incidence of 21% in this series. What were these stroke mimics? Some of them were psychogenic, musculoskeletal abnormalities. I don't really know what that means, honestly. Delirium, this periodic hypertensive episode, really uncommon, just one, but I work with somebody that's seen that happen. Those are under sort of the benign etiologies of stroke mimics, and then there's the not benign ones where it's not a stroke, but it also is something else that is not great to have. So neonatal seizures, metabolic strokes, post-ictal paralysis or paresis, ADEM, tumors, cerebrolitis, and we have seen almost all of those in our practice. This is sort of the public service campaign that is out there nationally to alert people to stroke in adults. It's the FAST campaign. And a lot of pediatric stroke neurologists advocate that for kids we call it FASTER. And the F is focal deficit, A is arm weakness, and S is slurred speech. T is if you see those things, it's time to call 911. And the R for kids is for remember. Remember, kids have strokes too. This is a picture of the current UNMH Pediatric Acute Ischemic Stroke protocol. This is the ED-based algorithm, and it's sort of piggybacked and built upon the adult stroke algorithm. They see anywhere from 2 to 5 stroke alerts a day, and we see about 1 to 3 per month. So much less frequent, but I think that they have a really good and well-oiled program that we're trying to learn from and work with. So you can see the time goals on the left. The first phase is in the first 10 minutes. We're saying if you have a kid that presents with an acute unilateral weakness and is between the ages of 2 and 17, you should call a stroke alert. That's just in our institution. You need to establish as well as you can, was the last known normal less than or equal to 24 hours ago? The reason that 24 hours is important is for thrombectomy. The thrombectomy guidelines are evolving and fluid, and their skill set is also evolving. And basically, they're able to help more and more patients with more and more vascular distributions of clot in longer periods of time. So it used to be that if you had a clot in your anterior circulation of your brain, if you presented within 6 hours of your last known normal, they could go in endovascularly and extract that clot and reperfuse that part of your brain safely. Well, more safely than harm. 6 hours for anterior circulation and 12 hours for posterior circulation. But now they're sort of extending it up to 24 hours at the discretion of the endovascular physician. The exception to that is if you have a clot in your basilar artery in the back of your brain, it supplies so many eloquent areas that if you don't treat that clot and you don't reperfuse that brain, the degree of swelling is it's pretty lethal in a large percentage of cases. So they'll go in and intervene on any patient with a known basilar clot that is stable enough to tolerate intervention. So if you go down this algorithm, you can see Initiate pediatric stroke alert, and then if you look to the right, those are all the people that get the page. There's the in-house neurology resident, who's the first responder, the PZD attending, the PZD charge nurse, adult ED charge nurse, MRI tech, CT tech, admin soup, which is nursing. Then there's the clerks that print out the name tags, and then either the neurosurgical or the pediatric ICU team, depending on where the kid's going to go. Currently, the neurosurgical ICU nurses are very well versed in taking care of stroke patients. So we had a 16-year-old that came in a couple weeks ago, and he actually ended up getting an intervention, and he went to the adult neurosurgical ICU just because that was the preference of the stroke doctor on at that time, and he did great. But just as well, these kids can come to the pediatric ICU. The nurses are trained, the doctors are trained. So we have 2 venues to take care of kids like this, which turns out to be helpful in the winter, particularly when kind of a struggle to find space for anybody. So if you go to the second half, in 10 to 30 minutes after you do a basic assessment, which is done by the PZD doc and the neuro doc, you decide if this kid is stable enough for imaging and if imaging is warranted based on the history and physical. This is a little different than adults. In adults, they'll just give anybody that has an acute neurologic presentation that might be consistent with stroke, they'll give all those people TPA and they'll just scan all of them with a CT and a CT angiogram often. For us, because there's a lack of evidence and because there's so much radiation, we do an assessment and a discussion between the 2 docs, and we sort of make a decision quickly, ideally within 10 to 30 minutes, about whether the kid warrants imaging to rule out a stroke. The best imaging is MRI, MRA with those sequences I described, but if the scanner is not available, or like we had a kid with braces and we thought that it would cause a lot of interference with the images, then time is of the essence, so you just shoot those kids over to the CT scanner despite the radiation. So then you get your scan, you read it quickly, and in the first hour you decide, is this kid a TPA candidate? Is this kid a thrombectomy candidate? If not, you start neuroprotective measures and you transfer them to an ICU for a monitored bed for 24 to 72 hours. TPA candidacy right now in our hospital, if you're 13 to 18, you are eligible if your last known normal was within 4.5 hours, and last known normal has to be normal. Even if you've had a headache that's out of keeping with your norm, you disqualified. So it's pretty stringent criteria, unfortunately. You also need to have a parent there to consent because of the lack of evidence out there. For thrombectomy, any kid that has a clot that's diagnosed in the MCA, the middle cerebral artery, the ACA, the anterior cerebral artery, the PCA before it branches, posterior cerebral artery, or the basilar artery, those 4 large vascular distributions, those are all eligible for an endovascular consult, which does occur by phone initially, to be evaluated for thrombectomy. And like I said, the window is now 24 hours. So time is still of the essence because time is brain, but you're not disqualified from a potentially life-saving treatment if you miss that 4.5-hour TPA window. Now, pretty much anybody who qualifies for thrombectomy also qualifies for TPA if they're within the age group and the time frame. So they might end up getting both, which is another reason that it's important to do all this in an institution that has the systems set up to care for them and monitor them afterwards. So, there we go. This is just sort of some QI stuff, like if a patient does get put on this pathway after a stroke alert, our goals are to have the initial ED patient evaluation within 10 minutes, notify the stroke team via the stroke alert within 15, initiate, this says CT scan, but for kids it's MR, initiate imaging within 25 minutes, read the imaging within 45 minutes, and then if they qualify for TPA or thrombectomy, try to make the door to needle time within that first hour. Usually if they're going to get TPA, it gets started in the ED and then it runs over 60 minutes. So they'll go up to the ICU with the medication still running. In adults, they have some pretty good literature that shows a 30% improvement in your neurological outcome for eligible patients who get TPA versus a 6% incidence of TPA-related intracranial hemorrhage and none of that was catastrophic hemorrhage. So 30% benefit versus 6% potential detriment, but in adults. And again, in kids, no data, despite a pretty good effort that I'll talk about. This is what's generally agreed to be what's required to have a pediatric stroke team and call yourself a center that can treat pediatric strokes. Fortunately, at the moment, we do have all of these at UNM, and everybody is very proactive in taking care of these patients. There are other hospitals around the region that have some of these resources as well. It's just to illustrate what it takes. Really, it's a complex multidisciplinary effort. And then this is just a basic diagram to really reinforce why we're trying to do all this. If these various areas of the brain are affected, these are the functions that are affected. So temporal lobe, intellect and emotion. Frontal lobe, it says smell, but obviously so much more than smell. Broca's area is speech, and you can read the rest of it. It's all pretty important. And then if you look at the top of the slide, the ACA supplies those areas that do speech, foresight, voluntary movement, the MCA, everything in the middle, the PCA, everything in the back. This is just explaining more of the same. If you have an ACA stroke, it might present as opposite leg weakness, changes in thought or personality. If you have an MCA stroke, it may present as motor and sensory symptoms of the opposite face, throat, hand, and arm, and it might affect your speech, like it did in one of our cases that I showed you. And the PCA stroke may present as visual problems, speech problems, or thalamic syndrome, like that 7-year-old that fell down the stairs. So this is how you assess kids after you, and adults after you decide they have had a stroke. This is sort of a validated 11-point scale that is on a 0 to 42-point system and is predictive of outcome. If your NIH stroke scale is less than 14, there is an 80% chance of a good outcome. If it's greater than 20, there's down to 20% chance of a good outcome. So there is a pediatric NIH stroke scale too, which helps us assess kids that are nonverbal and can't cooperate, and it just goes through all these same 11 areas. Usually the neurologist does this sequentially in the first 6 hours of presentation, and it helps them speak to each other in a common language that means the same thing to everybody. So what is the impact? I'm going to go a little bit quickly through these last few. They say about 30% of kids that have had a stroke for any reason, any size, do end up with special ed. 60% will have behavioral difficulties, and 15% will have diagnosable psychiatric disorders. What's the treatment? Number one treatment for pediatric stroke is neuroprotective measures to avoid secondary injury. What that means is keep the head straight and either flat or at 30 degrees. You don't want to turn the head and kink off any of the jugular veins to impede cerebral venous drainage. So head midline, flat or 30 degrees. You want to avoid hypotension because those watershed areas can be salvaged if they are given adequate perfusion. And you want to avoid hypertension because you have impaired cerebral autoregulation in an injured brain. So if you're hypertensive, you can cause a catastrophic hemorrhage around the area that had ischemic stroke. You also want to make the blood sugar normal, avoid hypoxia, avoid fever. So all those things are just what we monitor first in the ED and then in the ICU for the first 24 hours. So even though most kids don't come in time to get TPA, and even though a lot of kids don't qualify for thrombectomy, all of them will end up on aspirin or Lovenox for weeks afterwards, and this is usually managed by a hematologist. We talked about TPA. The function of that is it goes intravenously and breaks down the clot. This is different than Lovenox and aspirin, which just prevents extension of the clot, doesn't break it down any faster. The body breaks it down using its own mechanisms. TPA does break down the clot faster. You can also have intra-arterial direct TPA administration to the clot, but that doesn't seem like it's really in vogue right now. I think the risks were a lot higher than if you just give it intravenously without a lot of additional benefit. Thrombectomy is mechanically removing the clot, and hemicraniectomy is when you actually surgically remove part of the skull to allow that injured brain to swell out instead of swelling down, which can be a life-saving maneuver in some kids that have large volume infarcts with a lot of swelling. So our goals of therapy are to optimize recovery, prevent recurrence, and avoid complications. This is the one very excellent attempt that the pediatric community made to study TPA in kids with acute ischemic stroke. It's called the TIPS trial, thrombolysis and acute childhood stroke. 2010 to 2013, NIH funded 22 centers. It was a dose finding study, and they couldn't recruit, is the short version. In 3 years, 22 large volume tertiary and quaternary care centers recruited 1 kid, which was really, really disappointing. And then due to the financial and sociopolitical climate, the study got defunded. So now what's happening is individual centers are putting stroke programs into place like we did at UNM, and they're doing their own prospective observational studies trying to collect and share data. What we're using for a dose is 0.9 milligrams per kilo up to 90 milligrams, which is the adult dose, and we're using the time cutoff of 4.5 hours after last known normal, which is what they do for adults. This is just showing what I spoke about before in terms of why they decided that this is appropriate in adults, and it's now considered standard of care in adults, but not in kids. Talked about that a little bit. I don't think I should repeat that. Whoops. This is the long and important list. Oops. Wait, I have to. Yeah, long and important list of contraindications for TPA. So every stroke neurologist and every stroke program needs to have this at their fingertips because there are a lot of contraindications to consider. This is the indications for thrombectomy. Basically, the timing, the old timing is what I mentioned above. The new timing is up to 24 hours. It's at the discretion of the endovascular physician, which can be reached directly through the PALS line at UNM, and other hospitals have other systems. But in New Mexico, I think UNM is the only place that has an endovascular program that takes care of kids at the moment. And they can be reached through the PALS line at 505-272-2000. They're available for consults, questions. They provide an amazing service, I think. This is a kiddo from a couple weeks ago that had a left vertebral artery and basilar artery occlusion and did get diagnosed appropriately and did have thrombectomy and did have a good outcome. So you can see all those bright red arrows on the left demarcating the size and sort of territory of the stroke. It's pretty significant, pretty scary. And then I just did a diagram on the right to show you what the vascular distribution is of those areas, the left vertebral and the basilar. So if you think about if all that got occluded, I mean, look at the potential impact in terms of vascular territory. It's really scary. Oh, and this kid had a headache the night before, went to sleep, woke up, felt fine, walked to the bathroom, and didn't come out. So at like 7:15 in the morning, his mom went to see what happened, and he's collapsed on the floor, unresponsive. Turns out this is why. Again, no risk factors. So these are pictures provided by Dr. Sordi, one of our endovascular docs at UNM who did his thrombectomy. And you can see at the top, like the black is contrast within the vascular system going in patent blood vessels, patent arteries. And then it stops at the place where there's a clot in the basilar artery. And then she just did this second image to show you where that vasculature correlates to like his body, his face. And then if you look at the third picture, that is after clot removal, and the blood is flowing. So I think this is a pretty eloquent demonstration of the impact of those interventions. And then clinically, he also did really well. Whoops. So neurosurgery, we think that all stroke programs should be in a place that has neurosurgery for intervention and backup. The two main things are evacuation of an intracranial hemorrhage, which can be due to extension of an ischemic stroke or a complication of therapy like TPA. And then the second thing is if you need a life-saving intervention like a decompressive hemicraniectomy, obviously they are the people that do that. So I spoke to this a little bit before. What are neuroprotective measures? I guess I forgot to mention a big one, which is seizure control. So you will see a lot of kids on empiric Keppra for a few days to a few weeks, depending on their course. And these are some outcomes from a Canadian registry that looked at 900 pediatric patients with stroke. 22% had moderate deficit over time, 10% severe, and 14% didn't survive. So I would call this a low frequency, high acuity entity. I think it really behooves us to spread education and awareness. It's great if you have sort of a regional stroke center that has a well-publicized, well-understood stroke protocol. And along those lines, I think we have 2 or 3 primary stroke centers in the state, and UNM is applying for what's called a comprehensive stroke center certification, which speaks to the endovascular thrombectomy portion. Of course, none of these designations include kids, but we think they should, so we're going to tap into the expertise of our adult physicians and use it to help our kids too. So if you suspect stroke, I'm sure you have your referral networks and your methods, but you can always call the UNMH PALS line no matter where you are in the city or the state. The number is 505-272-2000, and I would advise this script. Say I need to speak to the pediatric neurologist on call immediately about a possible pediatric stroke. And you'll get patched into 1 to 4 people. You may be on a conference call, and then we'll figure out what we can do as fast as we can do it. Helpful information to have when you make this call, if possible, is the last known normal neurologic exam, past medical history, allergies, medications, and hang on to a parent for consent. So that's it. I'm happy to take any questions, and thank you so much for your time and attention.
So I have a question.
Sure.
We're waiting to see if anybody else does. In the presentation, with the hemiparesis, vocal changes, headache, seizures, fever and prodrome was listed.
Yeah.
By up to 40% of the time. So
I think what they were trying to say with that is don't exclude stroke just because a fever is present.
Okay.
You know what I mean? Like you could definitely have bronchiolitis and a stroke. You could have meningitis and a stroke. So I think just to stay aware as pediatricians that common things are common, but every now and then an uncommon entity can insert itself into that situation too.
Okay. And then one other question. So for the kids who you've seen, there was the 17-year-old and the 7-year-old who were previously healthy. Did you figure out why they had their strokes?
Nope. So frustrating.
Yeah.
So super frustrating. Yeah. There was one kid, an 8-year-old, that had a family history that wasn't really discussed or elicited until all this stuff happened to him. And it was a family coagulopathy. And then there was another kid whose mom was adopted. So she did not have a family history, but she had herself experienced a DVT at some point in her life, which may or not be related to a coagulopathy. But aside from that, it remains a little bit of a mystery.
That is frustrating.
I know.
Thank you from John Helm. It's a nurse at First Choice.
Great. Thanks for listening.
And of course, if that's okay, I can forward any questions that come in as we close out here. I can forward those on to you via email.
Sure.
And maybe you can answer those. And just one more time, wanted to make sure everyone had chimed in for their CME CEU certificates. And if you haven't, go ahead and chat in. I'll leave the room open here in Zoom for a few more minutes, so you have time to do that. And there's the slide I needed. And so thank you very much for that. And I do have a survey that we do every time we have one of these sessions. So I know a couple people had to run, but let me grab that and I'll post that here for you as well. So those who are still in the room can, please, if you don't mind, go and fill out that survey for us. And it does help us improve our technology, our topics, and just our delivery system here. And I think with that, I don't see any other questions coming in, so I think we can go ahead and end our recording. And thank you both again.
Thank you
For coming and presenting. And thanks, everyone.